Okay, everybody, welcome to today's acid-base lecture series. I'm going to continue where I left off last week, where we were discussing hypokalemic renal tubular acidosis. And remember, hypokalemic RTA can occur both in proximal and distal. So where we left off last time was initiation of a discussion as to how the kidney responds to what we call an extrarenal metabolic acidosis. And this means a metabolic acidosis that's not due to the kidney. Now, the reason for segueing into this topic is because some of these responses are what causes the metabolic acidosis in RTA. So when someone says to you, why does someone with who has renal tubular acidosis, I'm talking distal now. Proximal RTA, remember, is just the malabsorption of bicarbonate. It's to a great extent, if you had to answer someone asking you that question. The cause of the metabolic acidosis in distal RTA is much more subtle and requires some knowledge of how the kidney normally responds to an extrarenal metabolic acidosis. So that's the reason for going over this now. So moving away from RTA for a second and addressing this question, there are a number of responses the kidney has to ameliorate a so-called extrarenal metabolic acidosis. An example of that would be starting a hydrochloric acid drip, getting lactic acidosis, ketoacidosis, any reason for a proton load that has nothing to do with the kidney being the cause of it. So the kidney just doesn't sit there idly. It recognizes that there is this proton load and tries to make the bicarbonate not fall. So it tries to keep the bicarbonate at its normal level despite the proton load. The kidney doesn't just keep doing the same thing. Now, it can only do this when you don't have CKD, when you don't have type 1 RTA. All the physiologic mechanisms have to be normal in the kidney to prevent it from occurring. Now, that should also make you think that if the kidney is responding normally, depending on the magnitude of the proton load, I may not see a metabolic acidosis. And that's very true. So you always have to think of it that you can have a lactic acidosis occurring, ketoacidosis occurring, and the blood bicarbonate will not change because the kidney is able to respond appropriately. Doesn't mean you don't have the input of protons. It just means the kidney is able to compensate for it. So the lack of seeing a drop in the bicarbonate, you have to always remember for the rest of your career, in an extrarenal metabolic acidosis does not mean that you don't have the process. It just means that the kidney is able to compensate, and you only see a drop in your bicarbonate when the kidney can't compensate sufficiently. So let's say I have a lactic acidosis. We'll pick an arbitrary number of magnitude 10, let's just say. If the kidney is able to compensate, then you won't see a drop. Now, if I increase the magnitude to, let's say, 20 or 30, the kidney can only compensate up to 10. And now you'll see the drop in the bicarbonate. Those numbers don't have any units. They don't mean anything, but just to give you conceptually what's occurring. So one of the things that happens is, as I alluded to last week, and I'll review some of these things again because we'll go back to the beginning for those that missed it. The kidney in the proximal tubule always, even when you don't have an extrarenal metabolic acidosis, we still have a proton load. Remember, on an average North American diet, your liver is making about 50 to 100 milliequivalents of protons a day in the form of hydrochloric and sulfuric acid. So the kidney is always compensating for an extrarenal proton load. It just, lactic acidosis and ketoacidosis increases the magnitude of a proton load that always occurs. Now, the only time you don't have a proton load is if you're a vegan or some vegetarians. Those patients or those people are producing net bicarbonate. And as I said last week, you can actually correct the bicarbonate in patients with CKD just by changing the types of amino acids they ingest in their diet. So we showed last week, and I'll show that again, that different diets go from extremes of proton loads to extremes of bicarbonate loading. And something people don't think about. You think of, oh, you have to come along and give citrate, or you have to give bicarbonate to correct the bicarbonate concentration. That's not true. Depending on the magnitude of the CKD, just by changing the dietary proton load, you get the same effect. That also is why patients with CKD a given CKD have different bicarbonates? That should be a question you ask yourself. Why, if I have two patients with the exact same eGFR, does one have a bicarbonate of 21 and the other has a bicarbonate of 17? That should bother you. And the reason is they have different diets. And so they have different magnitudes of their proton loads. Okay, so the first process that you have to think of is that the kidney is always compensating for the normal proton load that we always have, and it does so by generating new bicarbonate. This is above the bicarbonate that it normally reclaims, and that bicarbonate comes up initially from glutamine converted to alpha-ketoglutarate. So glutamine doesn't get converted to new bicarbonate. The glutamine first has to be metabolized in the mitochondria of the proximal tubule to a substance called alpha-ketoglutarate, and it's the alpha-ketoglutarate, when it enters the Krebs cycle, that two new bicarbonate ions are created. And so that's the major source of new bicarbonate. And that, by the way, is the problem in CKD. Patients, as they develop worsening CKD, the kidney just isn't able to take up glutamine sufficiently. And so the kidney loses the ability to make new bicarbonate. And that's actually the reason why patients with CKD develop a metabolic acidosis. If someone asks you, why is the patient's bicarbonate dropped? You have to answer, the kidney isn't taking up glutamine properly, isn't creating sufficient alpha-ketoglutarate, and isn't generating enough new bicarbonate. Now, the other thing that happens is normally, as I mentioned last week, the kidney sends 60%. Now, in this process of generating new bicarbonate, unfortunately, there's a byproduct called ammonium that's made. And that ammonium has two exit routes from the kidney, like everything else. It can either go into the renal vein or the urine. When it goes to the renal vein, it gets back to the liver and is converted into urea. And that's a problem because the urea is made up of two bicarbonate ions and two ammonium ions. So taking this ammonia and converting it to urea is going to use up bicarbonate. And that's going to prevent the bicarbonate from matching your daily hepatic proton load. So you have sort of two opposing forces here. One, you want the new bicarbonate to match the daily hepatic proton load, but bicarbonate is also consumed in the urea cycle. So when the urea cycle increases, you don't have the same amount of bicarbonate that can be used to match your daily hepatic proton load. And ammonia, when it gets back to the renal vein, drives the urea cycle. In fact, as I mentioned last week, you can take a liver, isolated liver on the bench, and just put more and more ammonium chloride into it, and you're going to have the hepatic vein having less and less bicarbonate coming out as the ammonium is consuming that bicarbonate in the urea cycle. So remember, whenever you see your BUN, it's made up of two ammonium ions and two bicarbonate ions. You had to consume bicarbonate to make urea. Remember that. So normally there's 60% of the ammonia put into the urine and 40% of the renal vein. So we do consume 40% of the bicarbonate that we wouldn't otherwise if we put 100% of the ammonia in the urine. The kidney doesn't quite get that far, but what it does is it repartitions the ammonium that it makes in that reaction in the mitochondria of the proximal tubule and sends 80% into the urine and 20% in the renal vein. So what that does is it actually frees up some of the bicarbonate that would normally be consumed in making urea and has it available for now this excessive extrarenal proton load. Okay, so you don't make as much urea as you would otherwise because you're sending less ammonia back to the renal vein. There's also new renal bicarbonate generation from this substance that we explained last week that I'll show again called titratable acid excretion. That's just a fancy word for H2PO4. You take HPO4 and you convert it to H2PO4. That proton that converted it to H2PO4 came from carbonic acid in the cell. So by definition, you generate one bicarbonate ion intracellularly for every proton you secrete into the lumen. And this occurs in the proximal tubule and the collecting duct, depending on the pH and the pK of this reaction. And then the last thing that occurs is you turn off ureagenesis directly. Not only does the kidney send less ammonia back to the renal vein to generate urea, but urea directly is affected by the pH of the hepatic arterial blood. And so to the extent that you develop a metabolic acidosis, You always shut off ureagenesis. So you should remember that no matter what the cause of a metabolic acidosis, you have less generation of urea than you normally would. And that again is adaptive, if you think about it, because it also results to less bicarbonate consumption in the urea cycle, again, freeing up more of the new bicarbonate the kidney is generating to match the daily hepatic proton load. Now, what about RTA? Why are we talking about this? And the reason is that two of these processes are defective in distal RTA. And in fact, that's why you develop a metabolic acidosis. So the first thing is that the kidney loses its ability to repartition ammonia normally in the presence of a metabolic acidosis. In fact, it's even worse than that. The kidney can't partition as much ammonia into the urine at all, as we'll talk about in a minute. The second thing that happens is you don't generate as much titratable acid due to the defective proton secretion. Now, some people simplistically think, oh, it's just you can't acidify the urine. And that's not the correct answer. Never say that. The lack of being able to acidify the urine is a true statement, but that is not the cause of the metabolic acidosis. That's the concept. So then you have to ask, well, why does not being able to acidify the urine lead to other things that then themselves cause the metabolic acidosis? And the answer for that is you need to be able to acidify the urine to get ammonia put into the urine and not the renal vein. If you don't acidify the urine, the ammonia goes into the renal vein and you consume excess urea in the urea cycle. So that's one thing that's occurring in distal RTA. And the second thing that's occurring is you need to secrete protons to generate titratable acid. Now, why then is it wrong to say my patient couldn't acidify the urine and that's why they get a metabolic acidosis directly as a cause? And that is because if you do the math, there's so many few protons that are free in solution. When you say urine pH or when you use the word acidification, you're talking about the proton concentration in a fluid. And if you calculate the amount of protons that are free in solution in the urine, let's take pH 7. That's 100 nanomoles per liter. pH 6 is 1,000 nanomoles per liter. In 1 liter, you have 1,000 nanomoles. That's 1 micromole. You have very few protons that come out in the urine that are free. That's the concept. So the lack of being able to acidify that solution is minuscule as far as the amount of protons that are not coming out. The major reason is these two reasons. One, you need to acidify to capture sufficient ammonia in the urine to partition ammonia to the urine and not the renal vein. And secondly, you need to acidify that urine to create H2PO4. So it's the lack of these two things occurring normally that result in the metabolic acidosis. You just don't generate enough new bicarbonate from titratable acid excretion, and you have an inappropriate amount of ammonia going to the renal vein, consuming urea in the urea cycle. So the cause of the metabolic acidosis as far as the ammonia is you're driving the urea cycle too much in distal RTA. Okay, but if you ask, most clinicians or most nephrologists will say, oh, the urine isn't acidified normally. That's the cause of the metabolic acidosis. That is not a true statement on your exam. And this just shows things a little more clearly. So again, we're talking about the cause of the metabolic acidosis in distal RTA. It is not because the urine can't be acidified as a direct cause. That does lead to two other things. This is the first. So the lack of being able to acidify the urine, if you just go down here where the cursor is, has a consequence. So we have some sort of defect here, whatever the defect is, and we can't secrete protons normally into the urine. What happens? Well, this process of acidifying the urine is absolutely required to have NH3 enter the collecting duct. Why is that? Well, the ammonia gets into the collecting duct from the outside if there's a gradient for NH3 across this epithelium. It's passive. There's no active transport. It does use the RH proteins, as I showed before, but again, that's passive. You have to have an NH3 gradient. In the absence of an NH3 gradient, you won't get NH3 coming into the urine, to be converted to NH4 plus. So how do you get the gradient? You get the gradient through the process of changing the pH in the lumen of the collecting duct, because when the pH gets more acidic, you convert the NH3 there to NH4 plus. I'm not showing that conversion, but there's an equilibrium between NH3 and NH4 plus. And when protons are secreted, the protons bind to NH3 and are converted to NH4 plus, and that lowers the NH3 concentration and creates a driving force, a passive driving force, passive diffusion for more NH3 to enter. So as long as you can keep shifting the equilibrium from NH3 to NH4 by acidifying the urine and consuming NH3, NH3 continually enters. But if you can't acidify the urine, you lose the gradient for NH3 to enter. And that's it. It won't enter, but it has to leave the kidney somehow, and it leaves into the renal vein. So this is the first problem, as I mentioned, in distal RTA. You lose the ability to partition 60% of the ammonia made in the proximal tubule in the reaction that makes alpha ketoglutarate and new bicarbonate shown here. You lose the ability to send that into the urine. I show it as NH4 plus. We'll talk about this another time. It's actually NH4 plus that's made in the mitochondria, not NH3. And the NH4 plus then splits into an H and NH3 through a number of different transport processes first. And in the interstitium outside the collecting duct is NH3. But that NH3 and the proton actually came from NH4 if you look at things as far as mass balance. So acidification is an absolute requirement for lowering the NH3 concentration in the lumen of the collecting duct, creating a gradient then for NH3 to enter and for having that occur normally. And in the absence of that, that's why the NH4 plus leaves and goes into the renal vein. That's a problem, because when it gets into the renal vein, again, you're consuming this new bicarbonate that you made in the urea cycle, which you don't want to happen. So it's the excessive driving of the urea cycle in the distal acidification defects that consumes bicarbonate. If you didn't have urea being made, you wouldn't have as much of a metabolic acidosis. Now, no one has done a study, as far as I know, in patients with cirrhosis who have an abnormal urea cycle. They can't make urea normally, whether their bicarbonate was followed as much. You would think that if you can shut off the urea cycle, or you have pathologic processes in the liver where the urea cycle isn't working, that you would have a higher bicarbonate in those patients who also have a distal RTA, but no one's really looked at that. So this is the first process which is abnormal in distal RTA. And the second process is because of the inability to secrete protons, creating H2PO4 from HPO4, you don't generate a new bicarbonate each time you secrete a proton from carbonic acid. And therefore, you can't send more new bicarbonate in this process into the blood. And again, 60% of this occur. This whole process is called titratable acid generation and then ultimately excretion. 60% of this is a proximal tubule event, 40% in the collecting duct. So it's still occurring normally in distal RTA in the proximal tubule, assuming that you're not involving a transporter that's also mutated in the proximal tubule. And since the two transporters that we talked about last week that I'll refresh your memory with, the proton ATPase and AE1, are not players in the proximal tubule. AE1 is not at all in the proximal tubule involved in bicarbonate reclamation. And the vacuolar proton pump, which is mutated, is only responsible for a small amount of proximal tubule proton transport. The majority, as I mentioned last week, is the sodium hydrogen exchanger NHE3 in all mammals, including humans. That's not mutated in distal RTA. So that part is fine, except the part in the collecting duct of turning HPO4 to HPO4, H2PO4 would be defective. So it does play a role. Now, because of this abnormal urine to renal vein partitioning, you may recall that patients with distal RTA have a lower urine ammonia concentration and excretion. But in them, it's not because of a production problem to a large extent, like it is in CKD. CKD patients also have a low urine ammonia excretion and concentration, but there it's a proximal tubule production problem from glutamine. to alpha-ketoglutarate. Patients with distal RTA have not to the same extent a production problem, but more of a partitioning problem. Once it's produced, where does that ammonia leave the kidney? They have a problem sending it to the urine. They don't even send it to the urine normally, let alone that it should be 80% in the presence of a metabolic acidosis as the compensation I showed. They can't even send it 60% to the normal urine. So you might then say, okay, it goes back to the blood. That's fine. It's consumed in the urea cycle. That's okay. And so maybe I can get a clue for that by assessing the urine ammonia concentration in the urine. And so historically, we used to do it by anion gap, and then people that knew a little more did the urine osmolar gap, although this never became popular clinically. I don't know why. It was more in research papers, but clearly urine osmolar gap is more accurate. But now at UCLA, we can measure the ammonia, so we know directly what it is, and we don't have to think about these things anymore. Interesting, though, if you think about it, with the abnormal partitioning, with more going back to the renal vein, you might think, what about the blood ammonia? And it turns out, and this is like not known by any nephrologists or most people, you have to look at the original papers directly. There are 5 papers that have now described the blood ammonia going up in these patients. And so it's a real question whether there's anything else in medicine that lowers the urine ammonia concentration but raises the blood ammonia. And I've always felt this would be a great test specifically for distal RTA, although it's never been studied in patients clinically. There's no trials, but you will find these case reports, and they all have high blood ammonias. Now, when you start treating the patient, you're going to alter the partitioning, you're going to alter the ammonia production rate, you're going to alter the ureagenesis and the consumption of ammonia. So it has to be before, when the patients were seen initially. And since most of these patients are pediatric, because most of the conditions that cause distal RTA, pure distal RTA, are on a genetic basis, which is a pediatric disorder. And these cases are, I think, all pediatric. But be that as it may, you might want to, if you see a patient who you think has distal RTA, measure the blood ammonia also and see if you get the blood going up with the urine less than normal. That would be an interesting case to write up. So keep an eye out for it, and also start using the urine ammonia measurements in different scenarios, since we have it available. A lot of those cases can be written up, and a lot more is needed in the literature with direct ammonia measurements in many different disorders. Okay, so another thing that occurs in these patients, remember last time I said, these patients have multiple electrolyte abnormalities. That's the one unique thing about distal RTA. They don't just have an acidification defect. They have other electrolytes involved, and you need to know all of them. Because if you miss this, you're not going to get the right result on an exam, and you're going to miss things clinically. So one of the things they have is they have calcium handling disorders in the kidney. I'll call it that generically. And this can involve either hypercalciuria. Remember, the normal calcium excretion rate is about 250 milligrams a day in women and about 300 in men. That's sort of the upper limit for hypercalciuria. Some people use 4 milligrams per kilo per 24 hours. You can use either, but theirs is above this on a normal intake of calcium, which remember is about 1 gram a day. So we're not talking about someone taking 5 or 6 tons a day. This is on a normal calcium intake. They excrete more calcium than they should. Other patients have calcification within the kidney, shown here. These are actually the ducts of Bellini. Remember, the ducts of Bellini are the terminal portions of the intermedullary collecting duct. Those are the ones that tend to get filled up with calcium. Calcium is shown here, stained with the dye that stains it black. They can also get calcium stones, and the stones tend to be calcium phosphate, not calcium oxalate. So you should always remember that patients with distal RTA tend to get calcium phosphate stones. Similar to patients with Bartter syndrome who get hypercalciuria, nephrocalcinosis, and calcium stones, they tend to be calcium phosphate. So if you ask 100 nephrologists, why do patients with distal RTA get hypercalciuria? They'll tell you the low pH is ruining their bones, and that's where the calcium is coming from, and that answer is not true. And I'll show you data for that in a minute. It is known, however, that for many, many years, that if you ameliorate the metabolic acidosis. Not shown here is not the pH, but the blood bicarbonate concentration. If you correct the blood bicarbonate concentration, this is, I think, a study in dogs. I can't remember. I don't think this is humans, but if you increase the blood bicarbonate concentration, the urine calcium will fall. So that make you think, yeah, so what's wrong with my hypothesis that it's coming from bone? As I'm raising the bicarbonate, I'm getting rid of the metabolic acidosis. Less calcium should be leaching out from bone. And from this kind of study, you can't tell the source of the urine calcium. Remember, in hypercalciuria, there's three sources. It's either hyperabsorption from the gut, bone leaching, or renal tubular transport defect. That's true of any patient with hypercalciuria, no matter what the disease. So these three categories. Okay, so what we do clinically is we give K-citrate, and what we're trying to do is normalize the bicarbonate. Doesn't have to be 100% normal, but we know that raising the bicarbonate will lower the hypercalciuria. So we try to get rid of the hypercalciuria by raising the bicarbonate, usually with citrate, K-citrate, they're hypokalemic. We try to normalize the urine calcium excretion this way, normalize the citrate excretion, but we don't want the pH in the urine to go too high, because remember, the solubility coefficient for calcium phosphate is, around 7.3, 7.4, and you don't want to precipitate more calcium phosphate. So you've got to keep the urine pH below a certain level, and if it gets too high, remember the citrate is going to be turned into bicarbonate, and if the bicarbonate then gets into the urine and now your urine pH starts going up, you're going to get into a vicious cycle. So when the urine pH gets above a certain point, you want to use thiazides, which stimulate calcium transport in the distal convoluted tubule. Remember that when you get Gittleman syndrome, which is an impairment of the sodium chloride cotransporter, you actually lower the urine calcium concentration. So, or alter the urine calcium concentration. So thiazides help to lower the calcium in the urine, just like in Gittleman syndrome, by impairing the sodium chloride cotransporter. Remember, thiazides are identical to having Gittleman syndrome. The same transporter, NCC, which stands for sodium chloride cotransporter, doesn't work, and then that leads to problems with calcium absorption, hyperabsorption, actually. So we haven't then answered what's the mechanism of the hypercalciuria. As I told you, it's not bone, and it's now known to be due to this calcium channel called TRPV5 in the so-called apical, or the luminal, which means the urine side of the distal convoluted tubule. This is the tubule that also expresses the sodium chloride cotransporter. This is also the cell that you block with NCC and Gittleman syndrome. Okay, and there's two types. That's why it's called DCT2. There's a DCT1. DCT1 doesn't have the TRPV5 calcium channel. And there's also the segment after this in the collecting duct is called the connecting tubule. That's what CNT stands for. So the TRPV5 is only in these two segments, and there's some facts known about it. One, if you study a rat and you give it ammonium chloride to acidify the urine, or to make a metabolic acidosis. Remember, ammonium chloride causes a metabolic acidosis by driving the urea cycle and consuming bicarbonate. It's no different than the abnormal partitioning in distal RTA, sending ammonia that's made in the proximal tubule inappropriately to the renal vein. Anyway, you acidify the blood, and what you find is you have less expression of this transporter. So the expression of the TRPV5 channel is sensitive to the systemic acid-base balance. And in any metabolic acidosis, you make less TRPV5. It's also been shown that the transport is very sensitive to the extracellular and intracellular pH. Okay, so in the presence of metabolic acidosis, you have less TRPV5 channels and a direct pH effect where you have less calcium absorption into the cell, back into the blood. So this is the mechanism for the hypercalciuria. It's not bone leaching. It's a direct renal tubular transport defect. And that's in fact what occurs also in any metabolic acidosis. There might be some bone leaching of calcium, but there's a direct pH effect on renal tubular calcium absorption by TRPV5. That's what you need to remember. So this is just an example. In a normal mouse, you have, and forget the units, but you have control mice with this calcium excretion. You give ammonium chloride, it goes up. Acetazolamide, remember, causes a proximal RTA. You just, again, you get a metabolic acidosis. And what you see here is more calcium excretion. And the proof that it's not due to bone is in the next slide. First of all, if you look at the knockout mouse without TRPV5, look at the baseline calcium excretion. This is just a knockout mouse, normal acid-base status, missing TRPV5. There's tons of hypercalciuria here. So what this shows you also is the importance of this channel for absorbing calcium from the urine. Normal is 25 micromoles per day. This is 300. So you get hypercalciuria without this channel. But look, with ammonium chloride and acetazolamide, there's no response to that. You don't get any hypercalciuria from it, even though the ammonium chloride and the acetazolamide caused a metabolic acidosis. You don't get any more calcium coming out, which proves that it's, at least in this model, all due to TRPV5. The baseline's higher, and there's no response to metabolic acidosis. So showing you that the hypercalciuria response here was all TRPV5. And so that's the thought in humans too. So when someone says to you, why does this patient with metabolic acidosis or distal RTA have hypercalciuria, don't simplistically answer it's coming out of bone. That's not correct. You have to say there may be some component from bone. I can't say exactly, but the major component is a renal tubular transport abnormality due to TRPV5 impairment because it's so pH responsive. Here it's knocked out. Here just showing you that with it being present, but just by changing the systemic pH, you don't get the expression. Plus, not shown here is the channel activity is also responsive to pH. Independent of the amount, you get less transport for each channel that is there. Now, what about other phenomena that occurs? You can get a nephrogenic diabetes insipidus with the presence of hypercalciuria. And why does that occur? Well, it's known that when you have too much calcium in the lumen, these are other cells which you won't get into in the collecting duct, in other parts of the collecting duct. It binds to there's a calcium sensing receptor, you know, what is in the parathyroid that we inhibit depending on whether the patient can tolerate 125 vitamin D or not. So there's a calcium sensing receptor in many cells in the body. I'm only going to focus here on the one in these cells in the collecting duct. But the bottom line is when calcium is too much in the lumen, it binds the calcium sensing receptor, and that then prevents aquaporin 2 water channels from inserting into the apical membrane normally. And so you get a nephrogenic DI. Now you might think, well, that makes sense because that will lower the concentration of calcium in the urine. And people think that this is a homeostatic mechanism, at least if you're thinking teleologically. It's a homeostatic mechanism to prevent calcium precipitation, calcium phosphate or calcium oxalate precipitation when you have hypercalciuria, that any patient who has hypercalciuria, by preventing aquaporin water channels from going into the membrane normally, you absorb less water this way and you end up with nephrogenic DI, and that's a homeostatic mechanism in the presence of hypercalciuria to prevent calcium phosphate or calcium oxalate stones from occurring. There's also something else that occurs in that calcium in the urine binding to the calcium receptor, and it's unknown how this occurs, at least physiologically, or what the transport signaling is, but it enhances proton secretion in some models. And so the enhanced proton secretion also sounds like it makes sense because by acidifying the urine, you'll prevent the solubility product of calcium phosphate from ever reaching a point where it'll come out of solution by keeping the pH in the acidic range. That's great, at least for calcium phosphate solubility. And so these two things occur normally with hypercalciuria, but if you think about it, this can occur, which is why patients with distal RTA or any hypercalciuria can get a nephrogenic DI. In fact, this scenario is what you should answer when someone says to you, how does hypercalciuria cause nephrogenic DI? The answer is because you you have this calcium sensing receptor signaling to aquaporin to water channel insertion, and this mechanism is occurring. It occurs also in people with hypercalciuria acidification, but it won't occur, this is the important point, in distal RTA. So you lose the ability to enhance proton secretion when you have, by definition, a proton secretory process impairment for whatever reason, and therefore you lose the ability to prevent calcium phosphate from coming out of solution because the urine pH is going to 7, 7.1. It's going too high. Now, another thing that you find in distal RTA is they're hypokalemic, and this is not well understood at all. And the purpose of this slide is not for you to remember the mechanisms, not really important because none of them necessarily are true. But the point is that all parts of the nephron have been invoked as a cause, but no one really understands why. You can have patients with Sjogren's syndrome with distal RTA with a K of 1.8, 1.9. We do distinguish chronic from acute hypokalemia, and that's true of Bartter syndrome and any patients who have hypokalemia, in that if it's chronic, it means that the intracellular K is also down, and you don't have to panic and start giving potassium. And in fact, that's how patients get in trouble. I often say this when I'm attending in the clinic. If you have Bartter syndrome or distal RTA and the patient's K is 3, don't panic. Most MDs will. They'll put the patient on KCl tablets, which is inappropriate, because what happens is when you have chronic hypokalemia, because the intracellular potassium is also decreased, the membrane potential across cells is now normalized. So remember the Nernst equation, it's a constant plus the log of the K in over the K out. And it's the log of the K in over the K out that determines the voltage. If you have a normal K in over K out, even though in an absolute sense, each number is less or greater than normal, you won't get a voltage change. And it's the voltage change which causes the muscle weakness and the symptoms. So don't just look at the extracellular K and make a snap decision like most people do. The phenomenology clinically, the symptoms are caused by the ratio of the K in over K out. Now, because we can't measure the K in, we never know what it is. So you have to just go by chronicity. If the patients have chronic hypokalemia and the K-in is decreased, don't expect symptoms. The problem is clinicians always want to invoke a symptom. They'll ask the patient over and over again, are you weak? They go, yeah, I'm a little weak. And right away, they'll write weakness in the chart. And that's not caused most of the time by the hypokalemia if it's chronic. They could be depressed or other things going on, but many clinicians like to superimpose their desire to have the presence of the causal easy relationship between the weakness and the hypokalemia as de facto that's what's occurring. So take a great history. Don't just accept the word because that's what your mind expects to hear before you write down that the patient's symptoms are due to the electrolyte abnormality. The problem also is if they do have chronic hypokalemia, like these patients do, and they're fine clinically, and now you come along and give potassium, now you've raised the extracellular without the intracellular having time to go up. It takes time. It doesn't occur immediately. And now you depolarize the cells, and now they will get symptoms. So that's something you need to consider. Now, the problem is there'll be a lot of pressure from your colleagues and trainees. Why aren't you doing anything when the K is 2.8 and 3? And you can explain it to them, but most people don't accept it. So you're sort of forced to have to treat the patient, even though it's really not appropriate. And the patients will swing up and down because their K intake is never the same. Oftentimes they stop the pills. And now you're in this chronic cycle. Every time you see the patient of what's your potassium, and the patients now start to, do complain of the symptoms, and it's all MD caused. It's caused by that initial decision to treat. And I've seen patients with Ks of 1.8 that are completely fine. They have absolutely no muscle weakness or symptoms because they've had that low K from birth. But you can be darn sure every MD that sees them is going to have this inner need. And it's not inappropriate. It's because sort of how you're trained and what you're used to treat that K. And it's very hard to do because the kidney just dumps it. And so you end up giving a ton of potassium. And then you start thinking, well, should I treat on the output side with aldactone or miloride? And some patients don't tolerate that. So you end up with this vicious therapeutic sort of merry-go-round. And also the patients start hearing from you, my potassium, my potassium, my potassium, and then they develop this internal need to worry about it. So you should, as you go along, give a lot more thought to treating hyper or hypokalemia, especially if it's chronic. And that's why the converse, when we have patients on dialysis, they can tolerate Ks up to 6 or 7, they're fine, even though, as a trainee, you get worried about it initially until you get used to it. And the reason there, again, it's fine is because the intracellular K is higher than normal. Okay, and that's why oftentimes we don't see peak T waves in someone with chronic hyperkalemia. And that tells you, that's sort of an indirect assessment of what the intracellular K is and what that ratio is. Because remember, you only get peak T waves when you have an abnormal K ratio of outside to inside. When that ratio is normalized, you do not get peak T waves. So there it's sort of the converse thinking. So just remember that hypokalemia is part of the scenario with these patients just in distal RTA. Not talking about the hyperkalemic distal RTA, which is a whole separate group of disorders. So then how do we make the diagnosis? Well, you could measure the urine ammonia. Some people have suggested that, but low urine ammonia, remember, can occur from production defects like CKD, and they're not mutually exclusive. You could have CKD and distal RTA. You could have a production defect and a renal what we call a partitioning defect between the urine and the renal vein. So is there any test that's more direct? I'll first go to the historic test, which is below, which isn't done too often clinically. People tend to not definitively diagnose distal RTA in the hospital. They just rule out other things that might be causing the phenomenology. And if that's the case, it's just accepted, even though there's no definitive test. The definitive test that used to be done, that actually came from Mitch Halpern's paper, I think was in the 70s, a while ago, it was a very elegant paper. And the thought was that normally in the collecting duct, and I should have a picture of this, I apologize, I don't, but if you can just visualize, normally in the collecting duct, you don't have much bicarbonate in the lumen. It's all been absorbed prior to that by the proximal tubule and the thick ascending limb. So by the time you get to the collecting duct, especially the more distal portions of the collecting duct, the protons that are secreted bind to NH3 or bind to HPO4. So you make ammonium, as I showed, or you make titratable acid, H2PO4. There's really no bicarbonate buffer there. There's no bicarbonate there. It's all been absorbed. But he thought, well, what if I flood the collecting duct with bicarbonate by giving the patients so much bicarbonate that I exceed the proximal tubule and thick ascending limb's ability to absorb bicarbonate, and now there's a ton of bicarbonate in the urine, then I should be getting protons that are secreted binding bicarbonate. And if that's the case, I should be generating carbonic acid. Remember the bicarbonate buffer reaction. And then the carbonic acid will split up into water and carbon dioxide. So if I have proton secretion, normal proton secretion in the presence of bicarbonate, ample bicarbonate in the collecting duct, I should be able to generate carbon dioxide and use the carbon dioxide concentration as an indirect assessment of that I had normal proton secretion. Now, that thought would only be true if in the collecting duct you did generate carbon dioxide, which there's no reason to think you wouldn't, but that carbon dioxide did not get back absorbed into the blood when the urine got into the ureter and the bladder, and actually was still elevated when the urine came out. And he found, and other people had known from studies in the 50s and 60s, that indeed you can raise the PCO2 in the urine to about 30 or 40 higher in the blood this way. And it's not absorbed in the bladder because of what's called the surface area to volume ratio is correct, so that you don't get this excessive reabsorption. And the permeability of the ureter, bladder, urethra, given all the vasculature and other tissues, is such that you can get the PCO2 higher than blood. And if I did it in all of you, I would find that the PCO2 would go to 70 or 80. It goes high, it goes 30 or 40 higher than whatever the blood is. So people would measure the PCO2 in the blood with a venous gas if you want, and then take the urine and send it for blood gases. and measure the PCO2 in the urine, and it would be 70, 80. And if you saw that, you would say someone is secreting protons normally. Remember, you can't just assess the urine pH and say that they're secreting protons normally, because the urine pH could become acidic just by removing ammonia and HPO4. If you remove the buffers that are binding the protons, they'll all go free in solution. So looking at the urine pH does not help you, as I said before, say why the patient got a metabolic acidosis, and does not help you with the quantitation of how many protons were secreted per unit time. Okay, you can get whatever pH you want in the urine for a given proton secretion just by changing the amount of buffers, either bicarbonate or ammonia or HPO4. So this gives you a more quantitative assessment, not directly quantitative, but you needed to have so-called normal proton secretion per unit time to generate a PCO2 that was 30 or 40 higher than the blood. And so he thought, okay, it's known that normal humans do this. What if I study patients with distal RTA who have a proton secretory problem? In the absence of proton secretion, the bicarbonate that I flood the collecting duct with in these patients should just stay as bicarbonate. It should never be able to be converted to carbon dioxide, because you need that reaction of the proton and bicarbonate to make the carbon dioxide. And that's what he found. He found that in patients with distal RTA, the urine PCO2 stayed at 40. Just like blood, it never went above 40. It might have gone up a little bit. And that was in a very important paper. And that's how years after that, if anyone wanted to, they would be able to definitively say someone had a proton secretory problem, distal RTA. And as I say, it was never really done in the hospital because of the inconvenience of having to start a bicarbonate IV. You have to make sure that you get enough bicarbonate in to get the urine bicarbonate up to about 150 millimolar. It was a pain. Then you have to collect the urine under oil so you don't lose the carbon dioxide. Usually the patients peed into a hat, and then the MD would come along with a blood gas syringe and take the urine, cap it, send it to for blood gases. So it was a big pain to do. And in the last 15 years or so or longer, there's another way to test whether a patient has distal RTA, and it uses something you wouldn't think of, Lasix, and something in addition that you might think of, Florinef. And it's been known for many, many, many years. We won't get into why, because it's a little bit controversial still. But that when you give someone Lasix, the urine, you stimulate proton secretion in the collecting duct. You take that as a given just for now. And so there's a normal response to giving Lasix as to stimulating a given amount of proton secretion. And it's also known that if you give Florinef with the Lasix, you get even more proton secretion. So this became a urinary proton secretion. A better term would be proton secretion than acidification, because remember, the pH is not one parameter. It's defined by the buffer content of the urine too. But at any rate, it's called another way to, it's a way to test urine acidification. And you give 40 milligrams of Lasix and you give a milligram of Florinef. So that's a lot easier than starting a bicarbonate IV and sending the urine off for blood gases. And you just measure the urine pH after 4 hours. Again, most MDs, most nephrologists are not aware of this. So please remember this, because it may end up on your boards. And also remember it for the wards if you ever want to assess someone. And you measure the urine pH 4 hours later. And in all of us, it would go under 5.3. So if it's above 5.3, that would be an abnormal test. People also measure the stimulation of NH4 plus excretion, because remember, the NH3 crossing the collecting duct into the lumen depends on creating an NH3 gradient. And to the extent that you lower the NH3 in the lumen by stimulating proton secretion and acidifying the lumen, you'll get more ammonia in the urine too. So you stimulate ammonia excretion this way by transferring more ammonia from the interstitium into the collecting duct, and it should go up to this amount by 2 hours. And now that we can actually measure ammonia directly, you should be measuring this. And you have a way of doing it in your patients without having to get urine anion gaps or osmolar gaps and dividing by 2, that sort of thing. So it's a nice test if people on the ward say, does this patient have distal RTA? Get your answer back fairly quickly. So remember, the Lasix and Florinef test. So again, we'll just go back to the patient I showed last week. This is a patient who has a K of 2 and urine pH is decreased. The anion gap is normal. This is a compensated metabolic acidosis. If you look at the change in the PCO2 compared to the change in the bicarbonate, this is bicarbonate here. This was a blood gas. This, remember from the blood chemistries, it would be called total CO2, and it would be about 1 higher than this. And the urine pH was 7.1. And so this is what you would typically see in a patient with distal RTA. But remember, as one of you mentioned last week in response to the question, the most common reason for seeing this is diarrhea. Remember that diarrhea raises the urine pH, not because there's a collecting duct proton secretion problem, but because there's too much ammonia in the urine. So there's too much NH3 crossing into the urine and binding protons. And there's so much proton binding that occurs that even though the proton secretion is normal and actually above normal, remember all those 4 mechanisms that I talk about are occurring here. Alpha ketoglutarate production from glutamine is increased. More bicarbonate is being generated by the proximal tubule. But remember, that reaction creates more ammonia. And if there's too much ammonia being made, it'll end up in the collecting duct. And even though there's enhanced proton secretion, those protons can't go free into solution as easily to lower the urine pH. They bind to the NH3 and the urine pH is going to go up. So the lack of the pH dropping here does not mean at all you have an acidic proton secretory problem. In fact, you have more proton secretion than normal. You know that because you have more NH4 plus excretion, which you could also measure directly, by the way, when you send the urine off for ammonia. You'll find there's more NH4 plus. Remember, the normal on an average North American diet, there's about 50 millimoles put out per day, and that the concentration will depend on how much water you drink. If you drink a liter, you'll get back an answer of 50 millimoles per liter. If you drink 2 liters, you'll get an answer of 25 millimoles per liter. But the amount coming out on an average North American diet is about 50 millimoles a day. In this patient with an extrarenal metabolic acidosis, with normal ability to enhance glutamine uptake and new bicarbonate generation and produce more ammonia, you can get an answer back of 150, 200, 250 millimoles per day. And remember, the kidney is changing its partitioning too. Most of that ammonia now that's being made is going to be sent to the urine. And in a diarrhea patient, that's completely normal. They don't have a renal partitioning problem. And remember also that urea production is going to be shut off by the metabolic acidosis, so that the new bicarbonate that's being generated is now going free to match the hepatic proton load that's occurring from the intestine, from the diarrhea, creating the metabolic acidosis, but it's just not enough. And so the input of protons or loss of bicarbonate, depending on the cause of the diarrhea, is so great that even with the kidney enhancing all its 4 processes, the bicarbonate in the blood still falls. Okay, now why the ammonia production is high in these patients is because of 2 things. One, metabolic acidosis per se stimulates glutamine uptake by the kidney, conversion to alpha ketoglutarate, and generation of more ammonia in that reaction. And plus, it's been known for years that hypokalemia, hypo, not hyper, hypokalemia stimulates ammonia production. The converse is true also. If you have patients with hyperkalemia, it shuts off ammonia production. That's why, by the way, patients with type 4 RTA often can have acidic urine. I don't know if many of you have come across that. Even though it's called distal RTA with hyperkalemia, the urine pH can be acidic. So how is that possible? We just said they have distal RTA with a pH that's appropriately low. They do have impaired proton secretion, but it's not reflected in an elevated urine pH. And the reason is the hyperkalemia in those patients shuts off ammonia production, and they have very little ammonia in the urine. And so the protons that are secreted, even though the magnitude of the secretion is below normal, they can all go free into solution because there's no NH3 binding the proton. So if you lower the urine ammonia low enough, you can actually, even in the presence of defective proton secretion, still end up with a low urine pH. So that's the paradox in distal RTA with hyperkalemia. Many of those patients have a low urine pH. Okay, I think I'll stop there for today. And do any of you have any questions about anything I said? Okay, I think we'll stop there and we'll see you next week, everybody. Have a great day.